Thank you all for joining us today. If you'll give me just a moment, I'm going to pull up my slides. So what we're planning on doing is having some pause times for further questions. So you can either put them in the Q&A or it is okay to wait until our certain points to discuss your questions. Let's see, let's get moving. Yeah, so my name is Amelia Gilnett. I'm currently a Hopkins student studying Master's in Public Health and focusing on food systems, food nutrition, and health. So I have around 6 years of experience in food as medicine and 15 in the field of nonprofits overall. So Rachel Crossman of ProMedica has opted to join me today to discuss integration of nutrition interventions into healthcare. It's an exceptionally exciting time for this content. There's a lot happening in terms of policy shifts and also new examples of research that's occurring and advancements in access overall. So this presentation is first going to begin with the basics on food insecurity and what your organization might need to do to establish certain logistical and data measures to prepare to contract with healthcare agencies. So we'll cover the baseline, and then we're going to take a break, see how you're doing with that, review any content that you might want to, and then move on to discuss policy measures and specifics in healthcare to keep an eye on within your region. But Rachel gets to begin with helping you understand food and nutrition insecurity.
Thanks, Amelia. Hi, everyone. I will also mention, just as a housekeeping note, that Amelia and I are going to tag team watching the chat. So if folks want to put comments or questions as we go along, feel free to do that, and we can answer questions as we go. And certainly you all can talk with each other, which is always great. So to start off, just to kind of level set around my concepts, presumably most of you are very familiar with the different terminology around food and nutrition security being in the Hunger-Free Communities Network. But we really wanted to start here by highlighting that the language that we use to talk about households or individuals who are experiencing different versions of this challenge is really important. These things technically have different meanings. And so it's really important as we think about partnering between healthcare organizations and community organizations in particular, that we really start by ensuring we're talking about the same thing, so that the intervention or the program you plan is addressing the right issue for that partnership. So those concepts, which I won't read through, but we've defined them on this slide, and there's a lot of resources that you can find in the resource section and certainly online to think through the different aspects that we at ProMedica, the health system that I work for, really try to identify different interventions or programs that address each of these aspects of food and nutrition insecurity, rather than focusing or concentrating all of our effort on only one of them. So we think it's really important to be thinking about the different stages and different points along the spectrum. We also think about food and nutrition insecurity as essentially a symptom or an outcome of a deeper issue. So I think many of you probably think about this in the same way. There are many organizations, of course, that are working at different levels or different layers of the challenges. But again, we think about the different aspects of food and nutrition insecurity that we can address along these four categories that are around the wheel on the left. So these are things like you may live or work at a far distance from food, so sort of the physical access piece, which is different than whether there is actually healthy food available in the first place. And that is different from maybe the issue being that you don't live very far from a grocery store or other healthy food sources, but the healthy food costs too much to afford. So there are different pieces or different things, of course, that cause or drive food and nutrition insecurity. And so it's important when developing a program or a partnership that you're really clear about which thing you're actually trying to address or intervene in, because that directly, of course, will relate to the outcomes, but also to the population you're actually going to serve best with that program. And then on the right of this slide are just a variety of other aspects that impact food and nutrition security. So we think about them as secondary drivers, but really just getting into more detail about the different layers of this challenge and things that together make it very difficult for people to access and consume healthy foods. So this pyramid we have borrowed from other sources. We did not make this up ourselves. But again, thinking about our patients in particular, but also our employees and the residents in the communities that we serve, we again try to address food insecurity and nutrition insecurity at different levels. So looking at the top is where obviously folks who just really aren't concerned about food and nutrition insecurity are. You have access to healthy foods, you're not stressed about being able to purchase or consume those healthy foods, you have a high degree of food security, all the way down to what is called very low food security, which is, you know, folks in households who are really struggling on a regular, consistent basis to access and consume enough food and enough healthy food. So again, we try to look at different programs and services as where they are along the spectrum of which aspect of food and nutrition security from that previous slide, and also the degree of food insecurity that a household or an individual is experiencing. And this slide really just talks about kind of a theory of change. And this is what we at ProMedica focus on doing, but it's not, again, we're not that unique, luckily, in the healthcare sector. So you'll start to see a lot of health systems and insurance providers and other types of healthcare organizations really starting to focus on trying to understand and prove which programs or services really deliver outcomes for which population. So we're trying to get more precise, more scientific, closer to what we have in clinical treatment around being able to prescribe or essentially, you know, give a person a specific program or a specific food prescription based on data that has been developed. Right now, there isn't a lot of evidence around this question, so that's where there's starting to be a lot of exciting momentum and movement in trying to answer kind of what program, how much of the food support, in what format works for which type of person, and that's really going to start to drive the money and the funding to get it done. So again, this is in our world, but not dramatically different from how other people probably think about this, are different categories of what a food intervention can look like. So we organize them as sort of a lighter touch to heavier touch approach. So on the beginning end of the spectrum, you have nutrition education. So this can be anything from a handout that tells a pregnant individual what is you know, healthiest for them to eat during their pregnancy, or a nutrition class, all the way down to food infrastructure, which we really think about as being financial investment in the actual food ecosystem and practices like sourcing or purchasing food from local community farms or sustainable practices. In between those two things are the two most common that are happening today. One is screening and referral. So that's what most folks are doing now, which is essentially identifying patients who need some type of food support and referring them to a community organization who provides food support. But we're starting to see more momentum, and what's really exciting, what Amelia is going to talk a lot about actually doing today, are these food assistance programs. So this is going beyond just referring a patient out to someone like a food pantry and actually partnering with community to develop a new program or target a particular program towards a population. So produce prescriptions and medically tailored groceries and meals are some of the most common in this space, but hopefully we'll see a lot more examples and types of structures as people continue to innovate going forward. And again here, so without reading this very dense slide, and you'll get all of these slides, so I hope no one's feverishly taking notes. But this is really just, again, speaking to the amount of costs that actually food and nutrition insecurity cause in the healthcare sector, not to mention education and all kinds of other sectors. And with that high cost, there's a lot of interest in solving for that and reducing that. And so we really start thinking about what we need to know to make that happen. So this is, like I was saying earlier, some of these key questions around what the effect of certain programs really is on health outcomes and healthcare utilization. And that includes what amount of support, what type of support, the frequency of that support. There's a lot of different variables once you start looking at a program that we really just don't know today what the best answer is. And so figuring that out really has to happen through pilot programs and partnerships, and then sharing that knowledge with the rest of the sector.
Okay, and then we thought it would be best to get into the details of food as medicine generally. So this is from the Food as Medicine Coalition, a wonderful resource that you can find out quite a bit more about, and encourage you to. But they've created this lovely pyramid to further explain different levels and interventions of need. So on the prevention basis, as Rachel had said, produce prescriptions is one of the more common areas, and food. So essentially helping to enable nutrition security is one of these baseline factors. So that can be through pantries, that can be through SNAP or WIC or Farmers Market Nutrition Program interventions. The point being, it's really for a food insecure population, not necessarily yet into the chronic illnesses. And I misspoke there a little bit, but produce prescriptions would be the next layer up in that it's a food insecure population that is at more acute risk for acute and chronic illnesses. So say someone is pre-diabetic and they're needing assistance to receive healthy options. There's quite a few forms of vouchers and now even cards. We're going to talk a little bit more about the implementation of these programs because they're very variable across the nation. So there's a lot of options in how you can use them. And then the next layer up is medically tailored groceries. So this is more often for groups that are struggling to get maybe their A1C under control. So a group of diabetics with higher levels or cardiovascular diseases getting a little bit higher up, but still very functional, just needing a little more specified aid of what to consume to help their chronic illness. And then at the most intensive and more of a treatment level are medically tailored meals. So this is for populations that are critically ill. So often it is for cancer patients or someone that has gone through surgery and is unable to cook for themselves at home. And they're really tailored to both the person's chronic illness and what they're facing, as well as their preferences. And even some of them offer food to the family to be more all-inclusive of what the community needs are. And then I wanted to include more of a general overview of what's going on in different states. Massachusetts is one of the more interesting ones presently. They were the first with the Food as Medicine state plan. You can download their state plan on their website, and they actually offer a lot of tools as well to explore. So normally how this is, at least so far, functioning, as Rachel had also mentioned, is a lot of the times the healthcare provider themselves have begun to screen for different food insecurity needs or overall social determinant of health needs. Not everyone is on that level quite yet, but there's been a lot more momentum over recent years, and especially lately, to include that in their practices within clinics. Second, and I will say, you don't always have to have HIPAA compliance and EHR in place immediately. It is something to develop, and we're going to talk about how to do that and where to look for tools to get started in those areas. But even in my own experience, I actually began by having to send faxes back and forth to a managed care organization. So EHR can come at a little bit of a later date even sometimes, but preparing to do this safely is a part of this too. So after the referral system and after contracting, community-based organizations are offering the different varieties of food interventions. So depending on what you can offer, really writing that into, and yes, basically considering what your community needs are and what your provider needs are, you can utilize any of those options as long as it makes sense for you. And then in the grand scheme, encouraging advocacy and policy change to have sustainable funding with payers and providers. So currently these programs are paid sometimes by Medicare and Medicaid and accountable care organizations, even some private insurers. But as a population of interest, we have a lot further to go when it comes to securing this and making sure that you understand it and can amplify and access it. And then we wanted to get a little bit more into the basics of how to prepare specifically. So it is always important to really begin with what your strategy is and your values. I do think it's really important, especially in the nonprofit world, which can get a little chaotic sometimes, as we all well know, to have a long-term vision. These are very intensive interventions, and knowing how to step into it little by little, it can always be helpful. So in your handouts, there's actually I made a very long tool list to help with this. And there's 2 specific agencies that you can look to sort of evaluate where you are and where you might need to get ready. So the Food System Leadership Network has a really great overview of preparing your agency. And then I also have a tool from Mobile Meals that is focusing in on preparing to connect to healthcare overall. So both of those I would highly recommend utilizing and just sort of seeing where to begin. Second, of course, is staff and financial capacity. It's not minimal logistics. It's not minimal time. There's evaluation and transportation needs, also expanding your refrigeration options, other high capacity needs come up to be. And I'd also like to emphasize that we need to value our staff and not overtax them with too much. You want to retain your people, and it's especially important to value their time and insights in this, because it's really a lot of relationship building and very niche content. So by taking care of your individuals, I think this will have a much longer term influence. And then the next thing to really prepare is collecting and securing your data. So this can be both qualitative and quantitative. We're going to get into a lot more of what healthcare partners would really be looking for further down the line, but it's important to start setting up collection as soon as you can, or at least leverage what you already do have too. But we're going to get a little bit more into those details further out. And then lastly is to really identify the community partners and state initiatives that are happening in your space. So knowing if there's a food policy council nearby that you could be involved with, or potentially a population health network, knowing when your state Medicaid their application contracting sections are, or if they're applying for different waivers to include these programs, having a better idea of what's going on within them will really help in the grand scheme. And we also wanted to really include that you don't have to do it all by yourself. There's a lot of options on what these agencies and individuals need, of course. So the more that we can collaborate and interconnect, that lessens the load and can also result in a bundled payment potentially too. And then we did want to discuss that it's very possible to encourage nutrition in multiple ways and depending on where you are. So even personally, I began by working more in food pantry spaces. So what we had done was build around healthy food access options, partnering with farmers, having a lot more, behavioral strategies that we were implementing and social determinant of health, like toolkits and referral systems. So it can take a lot of forms. So sometimes it just depends on where you are and what you should be building. But ways to do this within certain spaces, you do want to emphasize choice whenever possible. Some different strategies for identifying healthier food options could be actually labeling high salt, high fat content, or high sugar. Having those out there is already taking a step closer to encouraging people to have healthier choices for themselves, and even bundling items. So sending people home with healthier meal options overall, maybe doing samples in this space, items like that all contribute to the same outcome. And then tracking those produce varieties and quantities has actually been something that really came in handy for me. Knowing which sites, so say you are working with farmers, keeping track of how many you're working with, what you're gleaning from them, what you're purchasing from them, that can always contribute to this actually. And then same for culinary and nutrition education. Those items aren't really to be overlooked. Also, this image is from one of the medically tailored grocery programs that I've put together before. So that's sort of one of the samples that you see of what you can offer and what you can grow from. And then just to get started, if you haven't already done this, it's always very important to assess the social determinant of health needs that are present in your population. Knowing which barriers you're going to need to tackle most is really a great place to begin. And that's the the broader base. Is it transportation? Is it understanding what to consume that's healthier? Sometimes, I mean, SDOH means a variety of things, honestly. So yeah, that can be relationships and housing and other basics, but knowing what to lean on and emphasize is really important. And then of course, tracking that. So knowing who your community partners are that you're sending referrals to, what those outcomes are, how many, if you're seeing higher volumes at certain times of the year. It's really important to gather all the information that you can to better understand how to serve people and to also pitch those ideas to healthcare partners down the line, because they're seeing the same health outcomes from these issues too. And then something that I haven't seen a lot of people implementing yet, but that is very helpful in developing these relationships, is monitoring health plan providers. So this means knowing who is providing healthcare in your area. And then also something that I've utilized before is keeping track of your population providers directly. So this can change often, so I would recommend doing that either annually or biannually to get a better idea of how many individuals are under each health plan. That way, if you are walking into a pitch to them, you'll know about how much of your population you're serving that could appeal, and if there's particular health issues that you're already serving within that population that might specifically be costly to them too. And then again, recording everything you can it can come in handy on multiple levels. So whether that be culinary education or recipe distribution, something that I've done before was also really highlight resource recipes and helping people switch out items. Again, it's a food insecure population that you're often working with. So educating people with flexibility and what can be interchanged can be another helpful tool to help advance this and knowing what they need most and delivering on that. And then we wanted to take a moment to see if there were any questions about the baseline content that we just presented before we get into the more technical content. And this would be a moment you can raise your hand and ask out loud. And because I'm sharing my screen, I can't actually see any, I don't see the Q&A in writing.
It doesn't look like we have anything in the chat or the Q&A, so folks can just jump in and talk, or you can put something in either of those boxes.
And if that's the basics, that's all good too. We'll keep going. Nothing, Rachel?
Nope.
All right, well then we'll continue on.
Awesome. So we thought we'd spend a little bit of time giving you some more detail and insight into what one health system is doing in this work. So again, all of us are different, but we're hoping that some specificity just gives some more concrete ideas. And again, I'm always happy to answer questions from a healthcare perspective for folks as well. So ProMedica is a national health system. We're based in Toledo, Ohio, and we have 14 hospitals in Northwest Ohio and Southern Michigan. So we have a somewhat urban footprint in a couple places, and then a lot of rural hospitals, as well as a physicians group across those states. And then we have some other clinical divisions across the country. So we have kind of a diverse footprint. And for that footprint, our team is a Social Determinants of Health Institute, is what we call our department. And we're responsible for helping the system address social determinants across all of the different care division lines. So on the next slide, Amelia. Perfect. The font is a little bit small, I know, so you can look at it afterwards much closer, but this is just demonstrating or illustrating that our institute, our department, is structured to support all of the health system sort of business lines. So we do everything from policy advocacy around social needs and social determinants of health to developing and implementing programs within the health system for specific groups of patients. We also work with our colleagues in HR to support our employees. So really across the span, a lot of health systems now have similar departments, whether they're more targeted towards community or population health, or they may have something around social determinants or health equity in the title. But we're starting to see a lot more of our colleagues or our peer systems have similar teams that are really sitting at a bird's eye level trying to do this work across the board. And those are really the teams that are great to partner with on things like a food program or a food intervention. So for us, as we think about specific programs and interventions, we really target a couple key elements. One is that we're very specifically trying to impact health outcomes. So we're trying to look beyond what we might call an output measure, so something like eating more fruits and vegetables, to the actual health outcome associated with that. Can we improve people's A1C? Can we reduce blood pressure? So things that are really, that we're monitoring on the clinical side are really important. And then similarly, we're trying to reduce healthcare spending. So we are really committed from a mission standpoint to the concept that we really don't want more people in our emergency room. We don't want people in our inpatient beds if they don't actually need to be, or if we could have prevented it. And so we see a lot of social related issues cause utilization of healthcare that people could have avoided. And if they avoid it, it's better really for everyone involved. And so we really look at programs or services that can also reduce that healthcare utilization. So keeping people out of the ER is the clearest kind of outcome measure around that. And then third, we look at scalability. So there are a lot of things that we do that are unique to some of our locations, but we really try to focus on programs that we could scale either to all of our hospitals, or even better, that we can share back with the sector and that other health systems can implement themselves in other parts of the country. So those are kind of the three categories or check boxes that we look at when we're thinking about new programs. And then again, in thinking about our focus on food and nutrition insecurity in particular, this is the same wheel that I was showing earlier in terms of the different aspects of food and nutrition security. So we are really focused on being able to increase sustained consumption of healthy foods. So one of those pieces is that we're looking for long-term impact, long-term behavior change, not just kind of the 3 days out of the hospital or the first week that someone is in our care. So on the far right, you'll see a list of interventions. These are all the different things that we're doing around food and nutrition security. And like I had said earlier, we really focus on trying to have different programs for different for people in different parts of the spectrum. So we have and operate a nonprofit grocery store, which really addresses physical access to healthy foods for anyone who lives in the area. And then we have really specific programs like medically tailored meals for specific patients after an operation or a surgery. So that's very tailored and specific. And then we kind of span across those and are constantly looking at new opportunities as well. This slide is just an example of what we mean when we talk about those health outcomes and reducing healthcare utilization. So this is the result of an analysis of one of our programs, which is a food clinic that we did of a little over 1,000 Medicare members who were using our food clinic. So they were receiving free food in addition to dietitian support on a monthly basis because they had told us they were food insecure. And as you can see on the right, we could see really attributable, so these are direct attributable reductions in care that folks were using. So reductions in emergency department usage, reductions in readmission compared to similar members or similar patients, and changes in overall cost of that member in a year. So these are the kinds of things that healthcare is increasingly looking for. And I think one thing that's important to mention on this slide is we aren't asking a nonprofit partner to come up with these numbers. We did the analysis of the actual costs and the healthcare utilization because we have that data. What we partner with is the actual delivery of the service, tracking who we refer, who actually does participate, who receives food, who shows up, so that we can then do the analysis on the back end. And then we share this data back with our partners so that they can also use it for fundraising and other kinds of advocacy work as well. So it's a really mutually beneficial relationship, in other words.
And then I wanted to discuss a few different examples of how to build up your programs. There's really quite a few options. And again, I did start at more of a pantry level and then developed into food as medicine along the way. So I wanted to share sort of some of the building blocks examples that you might be able to follow if that's your stage. So it is pretty ubiquitous to partner with farmers markets, and it's possible that that might be a great entry point for you as well. So in my experience, what I'd done was create a produce prescription program from looking at national examples of what was occurring, and then partnered with a federally qualified health center and also a payment provider system, which is two different entities in healthcare, to basically sign up their individuals for a produce prescription. This was actually after running the medically tailored grocery program, which I'll talk to you next about. So I created the produce prescription to really be a baseline to help them integrate healthy food options and lifestyle into their life after. So it was more of a training wheels program at first. And then we had also received funding due to COVID from the Department of Ag to build out another version of that. And that was kind of a once in a blue moon event. Obviously, it was COVID based, but I did want to bring it up because it required very particular reporting. So what I had to do was create the vouchers to pinpoint exactly what each vendor actually gave out to the person. So if you ever need help with designing these tools, I'm very available for that. But we did have to actually track by detail what they were purchasing with whom. So that was a different implementation. And basically I used those two programs to parlay that to a managed care organization to show them our engagement and then our outcomes and to develop a new relationship. So we actually partnered with them at more than one farmers market then to serve their individuals who were receiving CHIP and Medicaid. And they received $10 for 12 weeks at their own leisure, so they could come and go as they wanted. So that was a little bit more short term. The first one that I created, since it was able to be developed out of anything, I'd actually been able to write in more like 25 to 45 for families, depending on size. And for that was a 3-month period. So they can all be a little bit different. Another really good space to look into is the Farm Bill. I know that there were a few other lessons on that. So if you went to them, you'll know that 76% of the Farm Bill is actually going to nutrition. So that's SNAP and now produce prescriptions and even farmers market nutrition programs. So it can be, without getting into healthcare first, there's ways to build this up to begin with in order to make the step over after. And then some other ones to be aware of, just that likely a few organizations here are utilizing or could step into relatively easily are Double Up Food Bucks, which is related to SNAP and a national matching program. You can look more into that with the Fair Food Network. And then again, farmers market nutrition programs. I wanted to let you know that you can really add them up in a space like this too, because what we had ended up doing was offering the produce prescription programs and multiple streams of it, helped that farmers market also get Double Up Food Bucks. And I partnered with the county to do farmers market nutrition. I could give it out to senior citizens on the spot. So we were able to really combine quite a few resources to extend the level of nutrition access in person as much as possible. And then for medically tailored groceries. So when I created this, it took around 2 years. So it's quite a bit of work, but looked across the nation and who was doing what. And at that time I was in New York State, just to give you some context, but we had been under an 11 and 15 waiver, which I'll talk a little bit more about in another slide too, specifically. But that was an initiative to basically help decrease healthcare costs by connecting community-based organizations like nonprofits with healthcare providers and also public health agencies. So that emphasis was on bringing multiple members together. and basically also allowed us to fund different programs like this. So that's a little bit more context on how I was able to make those steps, and not every state is doing that. It kind of depends on where you are, but it's always helpful to kind of know what's going on in the grander scheme so you could replicate what you can where you are too. So what I really needed to do to get into the federally qualified health center was I created a logic model in order to show the different responsibilities that each agency would have. So our inputs and our outputs and our long-term vision of what that might be saving for them along the way. I did create a blank one for you of this program. Well, it has the details of this program in it as a resource as well if you haven't seen that option before. But really letting them know what they're going to need to do and like whose responsibilities will be on which team. So if that's going to be the physician team and who you would need as a champion, or if that's you're going to partner more specifically with their social care workers to identify people, or preventative care. Really knowing who you're trying to involve and what their level of involvement would need to be is a baseline step of what you will need to identify. Having a realistic timeline that everyone can stick to, especially around measuring biometrics, knowing when you'll look at what the impact of the program is, and the pre and the post tests, and what's going on along the way. And then for communication, I mean this in quite a few ways, because communicating on evaluating from one to another, of having like baseline meetings and connecting on how things are going. Also, how you're presenting outcomes and discussions to the media. That is another pretty important piece of taking care of it. And then including upstream barriers to the best of your ability is always going to make it more successful. So in my example, I had actually written in to have a registered dietitian so that we could have Medicab actually bring people to their appointments to pick up their share boxes. Since transportation is one of the main barriers of having access to healthy food, that was one way to step over that. And then I also included culinary tools, since usually people might be missing a couple things that are actually essential to utilizing these items. So we wrote that in, and we also did culinary education and nutritional education, along with community resource lists that were tailored to each geography, and quite a bit more beyond that, but we offered quite a bit. And then I wanted to highlight some of the people that really made it possible as well. So since bursitis and arthritis and other barriers to preparing food are often in this population too, we had worked with and hired a team of adults with developmental disabilities and intellectual disabilities to be our pre-slicers and to help me assemble the CSA share boxes. So that was a really wonderful addition, and helped those that had more intense medical needs actually consume the produce in particular. And then you also see one of the sample share boxes here. So what I had always tried to do was really create a box, and it was for 2-week periods. So items that could stay on for quite a while, some that were more, you needed to eat more immediately, having education of what can store how well. Also even like teaching people, I would always have citrus in mind, for example, but if they went bad, you can use it as a cleaning tool. So finding ways to really have it be applicable in the short and the long term of those spans of time was especially helpful. And I tried to include as many varieties of food as possible too. So in total, this program in its first year was able to source over 120 varieties of produce. We worked with 11 or 12 farms, I forget at the moment. And then for individuals who attended over 70%, we were able to decrease their ER utilization and also hospitalization rates by 1/2, and to drop their HbA1c, or their blood sugar levels, by a point or more. So those are really, really great outcomes from something that was only 9 months long. And yeah, I just wanted to also encourage you to give a shout out to those that really helped you get it together. It's always important to foster community further. So thanking our farmers was a way to bring the community together, and to also take part in sharing what they had offered in their contributions. And then moving on to medically tailored meals. There's more research in this area in particular, but it is also the most intensive option to implement. Again, this is home delivery. This is being medically specified to that individual's disease level. So it is quite laborious and expensive to implement, but I wanted to let you know that the Food as Medicine Coalition does offer incubation. Well, they do an incubator class if you are really interested in pursuing this further and want to learn from very well-established agencies like God's Love We Deliver, Community Servings, or Project Angel Heart. They've been doing this since the 1980s, so for 30 years. Most of them were born out of the HIV and AIDS epidemic and have just continued on to elaborate further in the field. And last month, there was an article published as a projection that if medically tailored meals were offered to as many individuals as are in need of them, it would actually save healthcare $38.7 billion annually. So there's quite a bit of research on what cost savings look like in this area available, even just in the resources that I shared as well. And then moving on to Medicaid. So just to get everyone on the same basis, Medicaid is very state specific. So federally, we only require certain populations and certain services to be included across the board. So each state gets to decide if they expand their services further or their populations further. So again, really knowing what's happening within your area is going to be the best thing to move forward on these options. So just to make you aware, a couple of ways that different food as medicine interventions are currently being paid for are these next few examples. So the 1915B waiver, and how this works, let me back up a little bit. So how this works is your state health organization would apply for these waivers to CMS, and that would also be okayed by the Health and Human Services, and then each state gets to implement these options within their area. So just to give you a baseline is really knowing that state level authority and to encourage them that these are options and you can mimic it in your own space if it's not currently happening. And then, so a 1915B waiver is a managed care waiver, and it allows them to implement a broader range of social determinant of health needs. And they can expand out to a broader segment of the population. So again, it's an application to do that. A 1915C is specific to home and community-based service waivers. So this is when an agency is applying to keep someone out of an institution. Skilled nursing facilities and long-term care facilities are some of the most expensive parts of our healthcare system. So this is a way to include these programs to keep people within their homes so they're not needing around-the-clock care, for example. And then an 11 and 15 waiver, as I mentioned, that's actually how I've been able to do the work that I've already described. Basically, that's what's called a demonstration waiver. So it means that the state has applied to utilize different ways to work in healthcare at that time. So they're trying new ideas, whether it be for broader social determinants of health or food insecurity specifically. So it's different ways to basically trial around what's going on. And just to turn your attention to, CMS actually has a wing of it that's called the Center for Medicaid and Medicare Innovation. So that's a really great agency to look up to see what they're emphasizing, because they're doing quite a few of these monitoring systems and even measuring things like health equity and finding ways to make that calculable along the way too. And then they want to provide a couple states to look to in particular. So Oregon is a really exciting example of coordinated care organizations. And this is an 11 and 15 waiver variety. So they're working more on making it a flexible payment system. And theirs is especially interesting because they keep their ear to the ground with what's happening in the community and are a really great example of holding people who are in Medicaid in these services to a higher level of listening to what they need and how these different implementations are impacting their lives. So all of these waivers do require a public hearing at the state level, but Oregon's done an especially good job of incorporating those voices of who they're serving, and have been doing it for quite a while. And then North Carolina is another really flexible, again, another 11 and 15 waiver, but working in social determinants of health and spreading out ways to interact with Medicaid populations and serve them through food insecurity needs and other areas as well. But quite a few states to learn from when it comes to these areas, not across the board quite yet. And then
I just wanted to let you know that we have about 13 minutes left. Thanks.
Oh no, okay. So I'll try to be really quick then. So managed care organizations are another one that are important to connect to. And they have quite a few ways. Since we only have that time left, I'm just gonna pull these up because essentially they're similar in action. So in lieu of services is similar to the other slides that I already mentioned. These are different ways that they can incorporate expanded services as long as they don't cost more than what it is on a typical pay for, a fee scale of implementing the healthcare practice. Sorry, I got a little flustered there. Let's see. We'll move it along. And then for capitation, that's really knowing like whether or not a health insurer has a per member per month payment plan. So they have to stay within a certain budget. So if you're saying you can save more money for them by offering these programs, knowing if they're a capitated health plan can really be in your favor. And then same for medical loss ratio. It's really being aware of the economics of what you could save them and why that would appeal to them further. So these are more mechanics to be aware of. And again, since we're fast forwarding through this, you can reach out to me later. And then it's very different for Medicare. So there's multiple plans within Medicare. Medicare Advantage currently does offer medically tailored meals in around 60% of their programs, a little bit more than that, but traditional Medicare does not yet. And then accountable care organizations are basically monitors of Medicare in particular. They're monitoring the population. They actually have report cards that you can review, just finding which one is near you and what the healthcare needs are and the populations that they're overseeing. Can be really helpful to develop these relationships. And they're actually a really great step into this world as well, because you don't always have to have all these tools in place on your own yet. Accountable care organizations can act as a mediator group, and they do get paid within the contracts, but they can be a really good middleman to be aware of. And then we did want to highlight ways to be ready to appeal to partners. So to become HIPAA compliant, I have done it. It's not that bad, I promise. So you can go to the Center for Health Law and Policy Innovation through Harvard. They have a checklist available for HIPAA compliance and first steps. As we've both mentioned already, knowing which utilization you can decrease is the next big thing that healthcare agencies would be looking for. So whether that be reductions in ER visits, hospitalization, skilled nursing facilities, admissions, long-term care, those are your main things that you can highlight and say that I can save you money by decreasing these needs. The biomarkers that you're often looking at, and as Rachel mentioned, it's not up to you to have to track that unless you do have an LPN on your site, and that's a step up. But normally you're looking at blood pressure, LDL, blood sugar, HbA1c, or even body mass index are the most common ones that we're currently looking at. And really a return on investment, it just means that you're describing how by investing in this program, we're able to save you a higher quantity of funding. And then also just being aware of the satisfaction that can go into that. There are measures that reinforce this in particular. So if you're able to help retain those individuals in the health plan because this is offered, that's a positive to them. Say for medication adherence, that's always a good thing. Or maybe if you're even looking at if they're retaining their primary care physician appointments, that's also a positive in your favor. And there are also publicly available ways to research these groups. So knowing quality scores can really be in your favor. Again, it's a way to look at what their needs are and what they might not be accomplishing quite yet. So there's things that are called HEDIS scores and STAR scores. and even other varieties. So you can do your research on who you're trying to appeal to in order to know what their needs are. And then we just wanted to give you a slide because there is a bunch of new examples and amplification of these practices across the nation, and it's very exciting. And then just finish out with a beautiful photo. So I'm going to wrap it up real quick and pop out of this screen so that I can actually see the chat. But please don't go. We're going to open it up for questions. So if you have anything for us, please go ahead and raise your hand and we'll chat with you now. Let's see. Sorry, I had to like really get through that last chunk, which is also the most intensive.
It's a lot of content. That's why I think it's awesome that they have in this platform both the slides, but then also a bunch of other resources. So people will have access to everything. But yeah, any questions or comments from people?
And the tools that are listed, I did put in a couple food insecurity measures, qualitative measures that you can pull from the logic model, a couple open source resources, ProMedica's examples of what they've saved over time. And then again, that 4-page list is quite a lot of insights. So that's meant to be helpful. Do you mind me asking if any of you are creating food as medicine programs right now? Now I know what my professors feel like. Let's see. Nope. Let's see. Well then, Rachel, if you don't mind me asking you a few more things, I will, just that way, if other people watch this with interest. Well, I was wondering, like, in your vision of what comes next for ProMedica, for example, like, what are you trying to expand more? Are you trying to do more cool foods to hospitals, or how do you see ProMedica evolving?
Yeah, so great question. We are really focused on a couple things. So one is we have some base programs that we have rolled out for or are available for all of our food insecure patients. So one direction that we're going to focus on in the next couple of years is really targeted cohorts of patients, so particular clinical diagnoses, to see what program models work best for them. And then the other side and the other kind of direction is that we're really trying to incorporate food as medicine work into our value-based care arrangements and our risk arrangements, which is very difficult to do. But we're working with, again, specific sort of patient populations where we do have value-based arrangements with payers to see and work with those payers on how to incorporate things like 3 days of food following discharge from a hospital or other types of food interventions so that we can really scale investment.
So there are a couple of successful examples of VBP payments too. We didn't really put that in the slides because they're just a beginning, but God's Love We Deliver would be a place to look to see what that might be. And we did get some questions in the chat. So what do you think are the most impactful opportunities for the private sector to contribute in this space?
So I am always, I come from a nonprofit background before being in healthcare. And so my answer is basically always the same to this question, which is for nonprofits in particular who have the ability to work in food as medicine and work with healthcare, I think the biggest need for them is capacity so that they can actually increase their ability to run a program before they can secure an actual contract. So we have a big chicken and egg problem in terms of how the money flows in healthcare. So I think one of the biggest things that companies can do is really strategically support the nonprofits who could be a part of this puzzle but need some flexible capital so they can hire more staff or procure more food or upgrade their technology system, as Amelia talked about. All of those things have costs, and the healthcare sector is not going to pay for all of it, unfortunately. So I think there's a really big opportunity for folks to fund some of that work really strategically. And I can talk ad nauseum about which and how to do that. So, but I'll stop there.
Wow, that's a good one. And then for the other question is, what are some tactics you use to navigate the silos and boundaries between the healthcare and nutrition food system worlds?
Amelia, I feel like you're the best one to answer this question.
Well, in my experience, I would say recognizing, so we are very siloed right now, but that is really starting to shift, and recognizing that health is both public health and also clinical health. And really beyond that, the starter kit of how we behave in our community, can afford things that would take care of ourselves. All of those pieces are upstream causes to these issues that we're trying to fix in these arenas now, right? So navigating, I mean, honestly, finding champions is one of the things that come to mind first. So knowing who's in the community health arena, or a population health or social determinant of health title in healthcare specifically, they're usually your avenues in. And then let me think. I would say it's really these boundaries are being more and more blurred, because even last month there was a really interesting Rodale Institute conference, actually, and I've been seeing a lot more, and it might just be because these are my interests, but there's more on soil health and organic agriculture, regenerative agriculture in healthcare, in educating healthcare providers. So agencies like that are starting to develop more networks, I would say, presently, and just like how to approach it. And yeah, like having food system discussions is all of these pieces together, whether it be an institutional source like the hospitals, for example, or coming at it from like, who is most likely to be injured on their jobs? It's healthcare workers, so like these things are intermixing in the food system arena. So food policy councils is another way that you can get multiple players at the table from all of these areas, and even private industry as well. A lot of community-based organizations. So it's ways to bring people together to advance these issues. And then beyond that, I think just verbalizing it more is super important right now. I feel like that's why I've come back to school, is to be better at articulating these things, and even signing up for events like this. That's a part of it. But I don't know. Did anything else come to mind beyond that for you?
I think the only other thing I would say is definitely the language. So like I said at the beginning, I think to the extent that it's possible to learn each other's language a little bit better, it helps a lot with those initial discussions, because people who are very busy, which is people in both healthcare and the nonprofit sector, if your first sort of entry point doesn't resonate, then it just doesn't go anywhere. And so I think being able to speak kind of healthcare to healthcare and nonprofit to nonprofit from the get-go is really helpful. And there's increasingly a lot of resources about terminology, and especially on the healthcare side, because the acronyms are really out of this world. And so there's a lot of things like that. And I think it's really important to not assume going into a conversation that the other person from the other sector knows your language, and on both sides. And so the things that we say, that we talk about, may not be the words that you use, but we might actually all be saying the same thing. So I think that's, like, from a base level, really important. And one of the great ways to do that is to hire from the other side as well. So as you build teams, look for people with healthcare experience if you're a nonprofit, look for people with nonprofit experience if you're in healthcare, so that you have that background as part of the internal team as well.
I would say, yeah, for social determinant of health side, you can look a lot into New York State to help look at all of those agencies. There's a lot around value-based payments and all of these factors. As Rachel was saying, if that's a language insight spot that I'd highly recommend. And then I know, Sophia, you have a couple announcements to.
I do. Thank you so much to you both for your presentation today. I really enjoyed it. So just to let you all know, up next, you'll have the chance to meet other summit participants through networking opportunities. So to join this session, click networking in your navigation bar on the left of your screen, then click join. So that concludes our workshop. To exit this section, please click on the red phone icon at the bottom of your screen now and then click leave. Thanks so much, you all, and have a great rest of your day.
You as well. Thank you very much.